Biopsychosocial Risk Factors and Co-Morbidities for Common Spinal Disorders. The concept of the biopsychosocial model was conceived in the 1970s and 80s by George Engel. This systems approach was an attempt to recognize that there are a complex of factors that interact with regard to health, which include both biological factors and psychological aspects. These psychological aspects are numerous, including personal, emotional, family, community, and other social factors. This model represented a desire to link science and humanism, and emphasized that patient-centered interviewing identifies the BPS needs of each individual patient. In a more global approach to the BPS model, it's important to identify which factors may be related to a given condition. Understanding the associations, comorbidities, and social context for a given patient with a given problem, the healthcare practitioner can better approach each patient. In the review we will examine, the researchers take a first stab at screening the current literature for the most important BPS factors related to spinal health. The title is A Scoping Review of Biopsychosocial Risk Factors and Comorbidities for Common Spinal Disorders by Green, Johnson, and Haldeman et al., published in PLOS One in 2018. So what is a scoping review? Unlike systematic reviews, scoping reviews do not focus on a highly specific question. They don't involve formal qualitative assessment of each paper reviewed, and they don't provide lengthy critical appraisals of the literature, but they do search for higher-level research, such as RCTs, cohort, case control, and cross-sectional studies. The authors suggest that, quote, spinal disorders should be considered as components of a more complex biopsychosocial model of health and not in isolation, unquote. So what motivated this review? World Spine Care. World Spine Care was established in 2008 with the mission, quote, to improve lives in underserved communities through sustainable, integrated, evidence-based spinal care, unquote. The Global Spine Care Initiative is a research proposal created by the WSC to, quote, reduce the global burden of disease and disability by bringing together leading healthcare scientists and specialists, government agencies, and other stakeholders to transform the delivery of spine care in underserved and low-income communities worldwide, unquote. From previous studies, they adopted the following three categories: spine pain of unknown origin, spinal syndromes, and spinal pathologies. Let's define each. For Group 1, spine pain of unknown origin, they define spinal disorders with history and examination findings that do not lead to a specific clinical diagnosis and have no diagnostic imaging, laboratory, or neurodiagnostic findings. An example would be lumbalgia. Group 2 spinal syndromes are differentiated as those spinal disorders with history and examination findings that lead to a clinical diagnosis, such as Facet syndrome. However, in this group, diagnostic imaging, laboratory, or neurodiagnostic findings typically do not confirm such disorders. And Group 3 spinal pathologies, which were defined as spinal disorders with history and examination findings that lead to a clinical diagnosis that can be confirmed by diagnostic imaging, laboratory, or neurodiagnostic findings, such as osteoarthrosis. But the researchers excluded tumors and pain disorders that are primarily of psychological origin. Now, what areas did they focus on? Risk factors, prognostic factors, associations, and comorbidities. Risk factors were, quote, any attribute, characteristic, or exposure of an individual that increased the likelihood of developing an incident common spinal disorder or morbidity or mortality as a result of that disorder, and were the results of clinical trials, cohort studies, case control studies, or reviews of these studies, unquote. Prognostic factors were, quote, factors that affect or determine the course of a disorder once the person already has the disorder, unquote. Associations were, quote, gathered from reviews of cross-sectional studies where risk factors could not be identified because outcome variables were not assessed before and after exposure, unquote. And comorbidities were, quote, any condition that may be associated with the spinal disorder being studied without assigning any condition as an index condition. And obviously, there may be overlap among these different designations. So why specific studies for specific factors? Well, recall that to determine if something is a risk, it must be followed forward in time in prospective cohort studies to determine the proportion of individuals exposed to the risk factor who develop the disease, or by searching in case control retrospective studies using case files, usually through databases, to determine what proportion of those who developed the disease were exposed to the risk factors. And in both studies, comparing that to those who weren't exposed who developed the disease and those who were exposed who didn't develop the disease, all require time. Because it requires time to establish that connection, cross-sectional studies, which are a snapshot in time, can't fully establish that relationship as a risk factor, but can identify associations and comorbidities that coexist at the time of the study. These studies are generally surveys. Cause and effect are actually quite difficult to determine scientifically, which is why this is not a focus of this search. The initial search yielded 3,453 studies. However, only 145 studies were included for final review as scientifically admissible studies. The researchers note that although they identified 14 different clinical diagnoses often reported by spine care clinicians and for which they received payment for care, there were only 3 with any evidence for risk or prognostic factors or comorbid factors. The researchers suggest that these recognized pain syndromes may not be any different than nonspecific spinal pain. So let's examine their findings for nonspecific neck pain risk factors. There were only 16 studies with only 1 meta-analysis. The remaining 15 were combined systematic reviews, which made pooling data impossible. And there were many opposing views, all of which makes the ability to draw conclusions impossible. The same was true for the thoracic spine. For nonspecific neck pain, there were 2 risk factors: high job demands and high monotonous work. The associations were female sex, psychological status, low levels of support at work, prior history of neck, low back, or other musculoskeletal pain, prolonged sitting or sedentary work posture, poor health, no or low levels of physical activity, and smoking. And comorbidities were overall poor health and musculoskeletal or general pain in other body areas. For nonspecific thoracic pain, risk factors were poor mental health and, interestingly, being an older compared to younger adolescent. And the associations were in children: female sex, postural changes associated with backpack use, and backpack weight. In adolescents, later age of puberty, and in adults, difficulty in performing activities of daily living. And the comorbidities were other musculoskeletal symptoms in both adolescents and adults, and mental health concerns in adolescents. And for nonspecific low back pain, risk factors included current and any history of smoking, and people with acute or subacute pain and negative expectations about their recovery. They were twice as likely as those with positive expectations to progress to chronic low back pain and have work absenteeism. And also high job demands, low social support, low supervisor support, low job satisfaction, and depressive symptoms. Interestingly, low job control, high job strain, low job security, and highly monotonous work were not identified as risk factors. And for nonspecific low back pain, associations were exposure to whole body vibration, such as driving heavy equipment, forklifts, and trucks, obesity, frequent bending and twisting, and increased age in workers. And comorbidities were psychiatric conditions, diabetes, headache, osteoarthritis, osteoporosis, chronic fatigue syndrome, fibromyalgia, cardiovascular conditions, sciatica, and pain at other body sites and other musculoskeletal complaints. And for spinal syndromes, there was a focus on sciatica, whiplash, and pregnancy. Risk factors for sciatica included obesity, overweight, mental labor, and current smoking habit. Risk factors for poor recovery from whiplash were a neck disability index score greater than 15, high initial pain intensity, and catastrophizing. And associations for sciatica were whole body vibration, being overweight or obese, smoking, high levels of physical activity, and markers for inflammation such as high C-reactive protein. And for associations for pregnancy, one study found pregnancy-related pelvic girdle pain and altered motor controlling kinematics of the pelvis, and another study found no association. Comorbidities for whiplash include psychological disorders, back pain, headache, widespread chronic pain, spinal degeneration, radicular symptoms, cranial nerve or brainstem disturbance, dizziness, dysphagia, fatigue, and obesity. There are many spinal pathologies discussed in this article, but we'll focus on a couple. Risk factors included smoking for lumbar disc herniation. Poor prognosis for neck pain was related to disc herniation associated with a workers' comp claim, and scoliotic curve risk was associated with degenerative disc disease in adults. Some associations were, for males, cervical radiculopathy, polymorphisms of vitamin D receptors and disc degeneration, disc space narrowing and spondylolisthesis, and whole body vibration, being overweight or obese, smoking, and disc degeneration. And for spinal fractures, there were several metabolic factors. For calcium supplements, there was no association with reducing fractures or increasing bone mineral density, and no reduction in vertebral fracture or improvement in vertebral bone mineral density with supplementation with vitamin D. However, supplementation with fluoride showed a reduction in vertebral fractures in adults when using a low dose, but not with other doses. For vitamin K, supplementation with phytonadione and minoquinone 4 reduced bone loss. Supplementation with minoquinone 4 was associated with a reduction in vertebral fractures. Isoflavones were actually equally effective at reducing vertebral fracture compared to hormonal replacement therapy. And some other interesting findings. Folic acid supplementation was protective against neural tube defects. Women taking carbamazepine or valproic acid, both anticonvulsants, had a higher risk for having babies with spinal bifida and neural tube defects. Other prenatal exposures considered to be risks for neural tube defects included influenza, chlorine, and maternal obesity. For scoliosis, the following were associated with progression: high initial Cobb angle, thoracic curve involvement, osteopenia, and age less than 13 at the time of diagnosis, and premenarche at diagnosis. Investigations into genetic variation showed that there was only one polymorphism that was associated as a risk for scoliosis. Recall this scoping review included studies from underdeveloped countries which illustrated some differences among populations. Access to healthcare, politics, work environments, and poverty all play a role. An example would be an individual with back pain, unable to stop working due to lack of compensation, complicated by lack of access to care, and failure of the employer to be obligated to provide a safe working environment. So what are some common themes and strategies that are take-home points for the practitioner? Encourage patients to lose weight, keep active, and stop smoking. For children and adolescents, warn against improper use of backpacks and excessive weight of backpacks. Screen patients for mental components, including depression, catastrophizing, and somatization, and work with psychological health providers to devise appropriate interventions or coping approaches. And for patients with workplace associations, discussions with employers about ergonomics, prevention, and workplace satisfaction modifiers.